wonderful good morning, ladies and gentlemen, dear friends and colleagues. What an amazing event, and welcome here to the Straumann Corporate Forum. You know, we do not just attend another dental congress. We attend the largest family event in the world, because here we can feel the ITI family coming together here in Singapore. And I'm very proud and happy to be part of that. And I would like to come here to you with three important messages. Message number one is that I would like to share with you the passion and the importance of the timing in implantology, because that's one of the most crucial parts in order to be successful in dentistry. Number two, the timing has been always an extraordinarily important topic for the ITI and for Straumann and for this partnership. And number three, I would like to show you why being a dentist is the best job in the world. And I'm going to start with you by introducing you to 6 of my patients. And at the end of the lecture, you will know exactly of each of these patients what is the right timing for this patient to be successful from a long-term perspective. And each of these patients has some issues with losing teeth in the anterior area. And our job is then to identify how to achieve success with all these patients. Let's start with the first one. This is Nico. Nico is the son of a dentist. He's 24 years old, and he serves as all Swiss men need to do for a couple of months to go to the Swiss Army. And this was before the drill, and he was jumping into the bunker and hit his tooth, and this was after he was jumping into the bunker. Then they are allowed to go home during the weekend, some weekends, and then I got a WhatsApp message from his father with this picture there, and said, "Hey, what are you going to do? My son fractured his center incisors below the bone level. Number one, tell him not to extract the tooth, because you want to be in the driver's seat to make a decision when it comes to the implant timing." And this was just a picture of him then on Sunday working on his son. Now, when we ask ourselves, what does Nico want? Nico is a young man. He currently has not much time, and he wants to have his tooth as fast as possible. So I think when Nico would be a dentist, or when he would wish what he could do, maybe he would choose an immediate implant. But he's also a person which wants to know a little bit more. The young generation is very informed. He wants to know what is the long-term performance of immediate implants. And here, today, we have so much more information than 15, 20 years ago. And the ITI and Straumann was working hard in order to gather this information. I'm just going to pick some of the literature. Here is one 10-year prospective study from Jan Cousin, which also sharpens the view to where we also draw our attention. We could see here, he was using this with another type of implant in very selected patients which are periodontally healthy, where we have thick gingival biotap, where we have intact buccal bone plate, only single tooth replacement in the anterior area. So everything controlled conditions. And he followed them up for 5 to 10 years. And the conclusion of this study was that we have stable clinical, aesthetic, and radiographic outcomes between 5 and 10 years. However, one important point is that even in these very controlled data, we have an advanced mid-facial recession, which was common after 10 years, as we can see it here on the picture. So we have so much more information on that. And there is other studies, substantial study, which can show that we have dimensional changes taking place in the premaxilla primarily, and that a contour augmentation at the time of implant placement might be taken into consideration for this type of indications. Now, over the years, we have also learned, and also the IT Consensus Conference worked hard on that, to have comparison between different implant time points. That was not available when we started doing this in 2005. And here the first one is to look at the two extreme ones, to compare what we do with a type 1 immediate implant to a type 4, a late implant placed with alveolar ridge preservation procedure. And in this systematic review, they looked at these two extremes. And they looked at cases, their studies with at least 6 months of follow-up, which is not that long, but it's a really nice comparative way to look at it, between immediate implant and implant which have been placed after ridge preservation procedure. What were the results? From a total of roughly about 600 implants which could be included, 300 were for immediate implants, about 300 were for implants which have been placed after ridge preservation. Also here, there was no difference in terms of hard and soft tissue preservation. However, when we look a little bit more in details regarding the cases, and again, it's so much about case selection. The ones which had an intact buccal bone plate, there was no difference between the ones with an immediate implant and the ones where the implant had been placed after ridge preservation. But the one which have a defect buccal bone plate, there the difference became statistically significant. So the conclusion was that alveolar bone defect might reduce the success rate of immediate implants, and that needs to be further investigated. Now the next comparison is between type 1 immediate implant and delayed implant placement in the way of a type 2. That means we wait 6 to 8 weeks. And that's again the group from Jung from Belgium. They had worked hard on this topic, and we have here another systematic review on this topic. And they ended up by having an implant survival rate in a type 1 area of 94.9%, which was significantly lower compared to the one which have been placed delayed after 6 to 8 weeks of healing. However, when you look at the overall result, there were not that many differences in this study. So, immediate implant placement demonstrates a higher risk for early implant loss. That's something we need to take into consideration. Now, this is what about when we talk about long-term performance. Now, Nico is also a young man. He doesn't have a girlfriend yet, but he wants to get a girlfriend, so he's also interested, how does it look like? So what are the aesthetic outcomes of immediate implants? I think here, over the last 15 years, many of you which have started early with doing that, you have a whole gallery of pictures which don't look the way we want to have them. And we want to go a little bit into depth and to ask the question, are immediate implant placed on a higher risk for aesthetic complications? When we look into the literature, there's one interesting study which combines the implant timing with the aesthetic result. And there we came to the conclusion that late implant placement was more likely to be reliable and aesthetically acceptable compared to immediate implants. And early implant placement, the type 2, implant placement remained the safest method to prevent unaesthetic appearance. And this is exactly in line with what we always have learned, actually, also from the ITI over the years. The question is, what is actually the etiology of soft tissue complications? And here we go back to our patients. And I'd like to share with you a prominent patient. This young lady here, she's a famous actress. And she came to me and said, listen, I need to have beautiful teeth within 4 weeks. And that's her smile at that time point. Why? Because she was the main actress in a movie which was nominated in the film festival in Cannes for being one of the selected movies to be the winner there. And she didn't want it to look like this. That's clear. But what are we going to do with that? So that's her within the magazine. That's her with a smile, which she was very unhappy about. And I have now 4 weeks' time to change this. What are we going to do? Now, what was the reason here? These were 2 immediate implants which have been placed by a very famous dentist, which is part of many organizations worldwide, which is very well known. The majority of you will know this person. And he's placing 1,500 implants a year. And I will never tell you who it is. But I want to show you that also somebody which is extremely experienced can have difficulties also in a case with an immediate implant. And this was the situation when we did a cone beam CT where the implant was positioning. So in the hands of somebody which was extremely experienced, this can happen. So we need to take this of utmost serious. Now it was clear within 4 weeks I won't be able to change that. The only thing I could do is to remove the crowns. I did a connective tissue graft, and as she wanted to have the diastemas, I could not provide her with a fixed temporary reconstruction. I could only provide her with a removable temporary reconstruction. And with this removable temporary reconstruction, she flew then to France, to the film festivals in Cannes. Now what happened there was, you can see here, she's the second on the left, and then in the center, that's the film director. And he's a very provocative guy from Argentina. And he decided to really create even more attention. And he did not allow her to wear the temporary prosthesis. Because in Cannes, they're all beautiful people, beautiful smiles. And she was then the one giving press interviews without the teeth. And that created all over the world, also in Switzerland, a lot of attention in all the media. Now, luckily, she never said that I'm her dentist, because otherwise I would be ruined. Now, in the meantime, I had time to get the cone beam CT before the tooth fractured. And this was the situation. Now we can see how actually delicate the tooth position is and how important the planning is, how important it is to estimate that this is a delicate situation. We do have an intact buccal bone plate, but the tooth is really outside the bony envelope. And also in the most experienced hands, it is a delicate situation, ladies and gentlemen. And we have learned that from literature. And again, the IT has done a lot there. Stephen Chen and Chris Evans, very important studies in terms of the bucco-oral implant positioning. And we have learned from all these studies that melt positioning of the implants is the most frequent etiology for aesthetic complications in immediate implant placement. And I wanted to share this case with you because it happens also in hands which are very experienced. So what can we do against that? What can we do against malpositioning? 2 things, ladies and gentlemen. Number 1, a thorough prosthetic planning, including the prosthetic outcome and also the anatomy. And number 2, use guided surgery when it comes to immediate implant placement in a flat procedure. Also when you're a superstar and think you can do everything by yourself. And this is what I did also here. I did the prosthetic planning, I had a guided surgery, I had to remove these 2 implants, I placed new bone level tapered implants in there in a much more palatal position, and I augmented the case, submerged the implants, and this was then the situation with the 2 temporaries in place. She wanted to keep her look with diastemas because that's her style. And this is then the final reconstruction here, as we could save the situation. It was a very delicate situation because we had to use 2 implants. Ideally, for a central and a missing lateral, we would like to have just 1 implant and a cantilever. But here, because she has all these models and actresses, they have then their style, and she has a style with the diastema. So this is how we could solve this situation. And this is how she gave interviews there in Cannes, and this is another view then when she had back her teeth and her style with the diastemas. Now, how do we achieve long-term success with different protocols? I think that's what we could address. We compared those different protocols, and we sharpened on the very important aspect what we need to look at. And now we need to consider how can we make the right decisions on all of these cases. And that's what we're going to do now in the second part. So we need to really take all these patients and make the right decisions. Going back to Nico's. Now we have a much better understanding of the situation. When we look at the clinical concept, he has a low to medium lip line. He has an ideal situation. The tooth has been root treated before already because it was once a trauma tooth. We have all intact buccal bone plates, ideal conditions here. And also when we look from a soft tissue point of view, we can see here we have actually nice soft tissues, even with a little bit of a soft tissue excess. That means we can also lose a little bit and still are on the right spot. Now when you look at this, with this information, which one of you would do an immediate implant? Please raise your hands. Don't be shy. Who would not do an immediate implant? Please raise your hands. Good, I think there were more people doing an immediate implant. I agree. I also think, yes, that's a good case for an immediate implant because he wants to have it fast. Let's look at the concept. He has a low smile line. He has moderate expectation. He wants to have a fast treatment. We have a medium soft tissue thickness, slight soft tissue excess. That's good for us. And we have a completely intact buccal bone plate, no bone deficiency. So that all speaks for an immediate implant. That's a good case for an immediate implant. So looking at the case, I extracted tooth as gentle as possible. We did a guided implant placement, as we did. We did a prosthetic planning beforehand. Implant is a perfect position, palatally positioned. And then we did an augmentation inside the bony envelope. Then he went to his dad. He got a temporary reconstruction and was then for 8 months in the Swiss Army. He came then back to me for the final reconstruction. And this is how he came back with the temporary reconstruction. Do you like the result? Some say like this. Look at that. When we look from the occlusal point of view, what do we see? We see a loss of the volume on the buccal aspect. From the frontal view, it looks actually pretty good. But when we look from occlusally, that's actually annoying. I don't like that. Because we have lost here a significant amount of tissue there. Why have we lost this part? What happened there? Today we have so much knowledge about that. Because today we know when we graft inside the extraction socket, like we do for an immediate implant, it's the exact same thing like when we do an alveolar ridge preservation procedure, where we just fill up the extraction socket. And what we can do with that, we can maintain up to 80–85% of the volume, compared to when we don't do anything, we lose 50% of the volume. However, we have to learn painfully over the years that when we just graft inside the extraction socket, we cannot maintain 100% of the volume. Now, we lose always about 15–20% without any grafting outside the bony envelope. So what does that mean? What kind of clinical consequences do we have out of that? And this was very nicely investigated with the group in Groningen, with Gary Rogabar and the team, where we compared immediate implant place with GBR procedure with no connective tissue graft versus the one with connective tissue graft. And we could conclude that the application of a connective tissue graft in the aesthetic zone maintains the mid-buccal mucosa level and volume significantly better than without, because we can compensate for this 15–20%. So what does that mean for our patients? Now let's take these two patients. And again, you can now realize it's all about case selections. On the left-hand side, we have a 68-year-old, very nice, kind patient. He comes with a fractured center incisor. He has a low expectation. He just wants to get the treatment done. On the other hand, we have a gentleman which is more picky, which has more higher expectations. And that has an influence on our treatment. Because this guy with low expectation needs an immediate implant with no grafting procedure. We have an internal grafting with bone grafting, but we don't need an additional connective tissue graft because he's happy also with 85% of the result. However, when we have somebody which is much more demanding regarding high expectation, we do need to further graft on the buccal side. Because we have seen with Nico, even in the best case scenario, we do lose this 15–20%. So low expectation means we leave it like this. In the high expectation, we do additionally place a connective tissue graft. And we can see here we have a little bit of this loss. But for this patient, it doesn't matter. We can see it also occlusally. He's the happiest man in life after this treatment. And also the other one is happy because we made the right selection for this case. Now, what about other cases? Here, this young lady. She came with a much more demanding situation. We have a very high lip line, very thin tissues, high expectations, and we even have a little bit of soft tissue dehiscencies. You can even shine through the root there. And we have a completely missing buccal bone plate, and the root is outside the bony envelope. So if you still like sleeping well, ladies and gentlemen, I love sleeping well, don't do it. Just go for a delayed approach. Go for a type 2 approach, which we have seen, which is very predictable from that point of view. Don't stress yourself doing an immediate implant. So we extract the tooth, we clean everything properly, we let it heal. And yes, we do have then a volume loss even within the first 6 to 8 weeks because we have no buccal bone plate there. This is then the time of surgery. We can see we have a through and through defect. I was able to place then a bone level tapered implant in there at the correct position. We were unfortunately have to the palatal and to the buccal a bone defect. Here we augmented it with 2 collagen membranes on both sides, buccally and palatally, a very established procedure, and then covering the flap and closing it. After 3 to 4 months, an abutment connection, minimally invasive, placing a temporary reconstruction, starting to condition the soft tissues, and at the end, this is what we have achieved. A very nice volume there, a predictable situation, thick tissues, very stable long-term results. And then here, we have here a situation then with a central incisor implant with a Cares abutment and then 3 veneers at the neighboring teeth. This is where we came from, and that's what we have achieved. And this is the final reconstruction of this patient, which we provide her with the best solution, and we can still sleep very well. Now let's come to the last patient. This is Nicholas, and Nicholas is also the son of a dentist. At the time I met him, he was a medical student, and he was just before his medical exams. And he was a bit stressed, and he came over with the father and the mother. The mother is a doctor, and he has a situation where he has a medium to high smile line. He has pretty high expectations, especially the parents have high expectations. And we start with a medium to thin soft tissue biotype, a slight soft tissue deficiency, and then look at this bone defect. A circumferential bone defect where the root is basically just standing without bone. Now I think we do agree that's not the case for an immediate implant. Is it the case for a type 2 implant placement? No, it's not for 2 reasons. Number one, he has no time within the next couple of weeks because he wants to focus on the study. And number 2, also after 6 to 8 weeks, I will have difficulties to be able to retain the implant here. So the safest way is here going for a type 4 implant placement with an alveolar ridge preservation procedure because that lets you sleep peacefully. And that's what we did here. We extracted tooth. We can see here also the lateral incisor was still involved there. He was still vital at that time point. I extracted tooth, did a ridge preservation procedure with bovine graft material in there. And 7 months later, he did come back, was happily passing his medical exams. And then I found a situation where I have an improved soft tissue situation and also a nice ridge here. Look at that, what we have achieved there with a simple technique. So I bring myself always into the comfort zone. And then I was able to place an implant. There was a little bit of a dehiscence on the buccal aspect. I compensate for the last 15 to 20%, as we have learned before. A submerged healing, then again, opening the situation, conditioning the soft tissues, and providing him with a beautiful Cares crown here. And how we have changed a very complex case into a more straightforward case. Now, how does the long-term success of this patient looks like? And I still owe you an answer, why do we have the best job in the world? Here we can see the situation 15 years down the road, just done last week. Still a beautiful situation, a little bit of a growth of 2-1, but overall very beautiful tissues, perfect bone level situations. And why do we have the best job in the world? Because we are part, not just of a long-term success, we are part of friendships. He started as a medical student, and he got infected by the dental virus because he loved what we are doing. and he switched from medical school to dental school, and he studied at the University of Zurich dentistry. After 3 years in private practice, he applied to become a postgraduate student in our clinic, and I'm assisting here during a soft tissue grafting. And now he became faculty member in my clinic. And isn't that a beautiful journey? And isn't that what makes our job so perfect? So let's come to the overall conclusion. What you need to take home, number one, is it's all about diagnostics and taking the right case selection. And try to sleep comfortably. You do this in the anterior area when you only go for immediate implants in case where you have low lip line, low expectations, sufficient tissue, intact buccal bone plate. When you have a delicate situation, when you can already smell it in the waiting room, that's going to be delicate. Don't put yourself into a difficult position. Go for a type 2 implant placement, very well documented, a typical ITI documentation, or even a rich preservation later on. Premolar is the discipline to do immediate implants. That's the best place to do an immediate implant. We need to have sufficient hard and soft tissue, but this is where we like to place immediate implants. And the molar area became a very important discipline, especially with the TLX implant, which allows us to even more and to better anchor our implants in that area to even provide here immediate implant. So with this, ladies and gentlemen, I come to the conclusion. And I would like to say thank you very much from the bottom of my heart, and thanks to my team in Zurich, which I'm very proud of, and thanks to Miha Pirch, which helped me a lot to put this presentation together. And I wish you an enjoyable Congress. Thank you very much.